The first lecture I'm going to give today is really kind of an overview of care work, how we define it, how we think about it, how we conceptualize it. And the second is a more technical discussion of time use surveys, what they tell us and what they don't tell us, and how their methodology might be improved. So it's a little bit more nuts and bolts of time use. So let me go ahead and share my screen. I think that it occurred to me while I was sitting here that in some ways the motivating question for this session, which I didn't think to put in the PowerPoint, is the following. Is care work undervalued and underpaid because women do it? Or are women assigned primary responsibility for it because it tends to be unpaid or undervalued? And I think the answer to that question is both. I don't think they're mutually exclusive, but what I'm going to emphasize in this presentation is the ways in which care work itself is prone to undervaluation regardless of who does it. That doesn't mean that it's not, the disadvantage isn't compounded by gender inequality, or that gender inequality doesn't play a very, very significant role, but just that there are some distinctive characteristics of care work that are really relevant to understanding both the structure of wages in the paid labor market and the tendency to ignore or invisibilize unpaid work. So kind of general overview of the care sector. I'm going to skim through that pretty quickly because I think we're all on the same page about that. Distinctive features of care work, especially those related to remuneration for it, bargaining power, distributional issues, and national income accounting, which I touched on in my last presentation, but which I want to keep coming back to as a kind of a recurrent theme. So think about the language that we hear economists talk about when they talk about the economy. There's a reference often to the manufacturing sector or the financial sector or the service sector. But there's also something that we could call the care sector that includes three industries that are traditionally kind of lumped in with the rest of the service sector. And these are health, education, and social services. Plus, there are care occupations that are outside these industries. So actually, most care occupations are in care industries, but the two things are not exactly the same, and I'll explain the distinction. But I think what's unique about the care sector is that it's including both paid work and unpaid work. So unlike the sort of traditional sectoral definition, it crosses the boundary of the market. So I'm going to draw some examples from the US because that's where a lot of my recent empirical work has focused. And really striking that 37% of all employed women worked in health, education, and social services compared to 12% of employed men. So there's a lot of segregation of women in paid care services. And there's also a lot of very strong division of labor in gender division of labor in unpaid care work. And unpaid care work is quantitatively really significant. If you define work, as most time use surveys do, as work that somebody else could in principle be paid to do for you, it really adds up to a lot of time, even in the most advanced, or certainly one of the most kind of commodified economies in the world, the US economy. So it's quantitatively really significant. And of course, a lot of that unpaid work is structured around the needs of dependents. So the pictures, as I think everybody now is really familiar with is that in developing countries, the picture is very different and also very diverse. Rates of women's participation in paid employment relatively low, not growing very rapidly, actually declining in some big countries, including China and India. This burgeoning informal sector. So segregation in the paid care sector is probably less relevant in many developing countries. Although I think I would really like to see more comparative empirical research on the relative size of the paid care sector and the unpaid care sector across countries. I think there's a really great research agenda here for empirical work. But the really interesting issue to me is that standard economic theory doesn't apply very well to the care sector. And one catchphrase that kind of dramatizes this is the phrase invisible heart, that yes, the invisible hand on the market is important, but we also depend very, very heavily on intrinsic motivation, commitments to care for other people, emotional connection, personal engagement. And economists have generally slighted the role of these factors that can't be subsumed under the rubric of narrow self-interest. So I think some of the language of institutional economics and of kind of industrial organization is helpful to detail, to describe the distinctive features. So concern for the well-being of a care recipient is likely to affect the quality of the services that are provided. And I think the reason I like that definition is that I know, not all caregivers are always totally committed to the well-being of those they're cared for, and sometimes, in fact, they're coerced to care. But in general, if we want to get good care, we pretty much want to find a caregiver who has some concern for the well-being of the person getting those services. So a lot of care provision is face-to-face, or it's hands-on, or it's on a first-name basis. And that can be true whether it's paid or unpaid, or market or non-market. And of course, that means that men as well as women are providing both paid and unpaid care work. So one way to describe this is that care work is relational. It's often individually specific. Consumers lack sovereignty. That is, they don't have a lot of choice over the services they're going to get. Often in the market, the payments that are made by the state or by private insurance. That's known as third-party payment. There's a large literature showing that tends to distort incentives that the market might otherwise exercise to allow individuals to vote with their feet. There's no voting. It just makes it a lot harder to choose another provider or find another provider if you're tied into a bureaucratic third-party payment system. And another feature of care provision that I think is really important is that it involves teamwork. And as a result, it's often really hard to identify individual value added. So what I mean by team production, well, think of education. It's not just the teacher you have right now, it's the other teachers in your school. It's the advisors, it's the guidance counselors, it's the, there's an ecology, there's an educational ecology. And also your output as a teacher depends in many respects on cooperation from your students. If your students aren't motivated, if they aren't engaged, you're likely to be a lot less successful as an educator than if they are. And that's also true for health services. Doctors really need cooperation from patients. They need patients to follow directions, to tend to their diet, their exercise, to listen to advice about health risks, and so forth and so on. So it just has a more collaborative and cooperative dimension than the production of a lot of material commodities has. Another feature that's often been remarked upon is that care provision is very labor intensive and perhaps resistant to technological change. Not totally resistant. I mean, here we are on a Zoom seminar We've seen a lot of technological change in education in the last year, but there seem to be parts of the process that that really can't be automated. And a lot of what's evolving is, an effort to figure out how you can, take advantage of productivity enhancing technologies without losing the personal connection and contact that's really intrinsic to the whole process. This is why we want to leave room for discussion, to make sure that there's some interaction. And care work, it's difficult to measure either the inputs or the outputs. So if you think that the value of the inputs and outputs should have some bearing on how much people are paid, you're kind of in a pickle, because it's difficult to measure them very accurately. And in fact, a big part of the difficulty comes from the big public spillover effects of care provision. You educate, you do a good job educating someone, they gain capabilities, and those capabilities benefit their employers. Those capabilities benefit their partners. Those capabilities benefit their neighbors. Those capabilities benefit society as a whole. So teachers are not really capturing a very large share of the benefits that they create, partly because those benefits are spread, over lifetimes. They're investments that have very, very big, very long-term and very diffuse kinds of payoff. I think it's actually helpful. Sometimes you hear economists use the term social capital to get at some of these externality and spillover effects. I guess I don't really like the social capital metaphor. I prefer to think of the term social climate, because it's something very complicated that affects everything that we do, that we don't fully understand, and that seems to be changing in ways that are making it harder for us to do the things that we most care about. And I think an emphasis on these spillover externality effects also aligns the discussion of the care economy with ecological economics and environmental economics in really important ways. And it helps decenter the market and market exchange and individual self-interest as the most, traditionally treated as the most important elements of the economy. I think they're actually pretty subsidiary and relatively minor compared to the relative influence of these spillover effects, which can be very positive or very negative. So there's a growing literature on what's known as the care penalty. And this is something that Paula talked about in her lectures. I'm just going to maybe kind of summarize and try to locate it within this discussion of the meaning of care. I think there's good reason to believe that women's specialization in care provision, it might be efficient. It might offer some benefits for society as a whole, especially if everybody else is reluctant to do it. But it's pretty clear, even if that were the case, it's pretty clear that it reduces women's individual and collective bargaining power. And it does so because of the distinctive features that I've just described, that it's very valuable, but it's not really valued because it's difficult to capture the value added in an individual transaction. And, there's a lot of historical background to this undervaluation. Historically, women's opportunities to specialize in anything but care were very restricted. Commitments to care are very costly, and they're kind of a sunk cost. People get attached, difficult for them to exit from care commitments. So there are private costs, but there are public benefits. And, even standard mainstream economics textbooks point out that you get problems when there's a divergence between private and public costs and benefits. So there's a lot of empirical evidence of care penalties. It takes many different forms. Looking at how time devoted to unpaid care work, especially maternal responsibilities, lowers lifetime earnings, increases risk of poverty. There are audit experiments that reveal discrimination against mothers in the labor market, even very subtle cues that suggest a job candidate has parental responsibility tend to reduce callbacks for interviews. And then there's also a growing body of econometric analysis showing that women in care industries and occupations are paid less than others with the same education and experience. And that's something I've been working on in the US case. Be happy to talk about that further if that's something people are interested in. So what's the distributional context here? We know that women are paying a lot of the cost. Who's getting the benefits of the existing regime of care provision? Well, it's pretty clear that employers benefit because they don't have to pay the full cost of producing labor. That is, they're taking advantage of these positive spillovers of human capabilities created by care provision. Men benefit because women are paying a larger share of the care costs, but men are also able to capture the benefits. And it's also true, and we shouldn't forget, that dependents, including children, sick or disabled people, the frail elderly, benefit from a reliable source of care. And in fact, I think one of the reasons why women continue to specialize in care provision is that in the absence of any other institutional arrangement for taking care of dependents, it's very hard to withdraw from that traditional responsibility. I mean, by definition, if you have some intrinsic concern for other people, you're going to be slow to exit from that responsibility unless you can get somebody else to help shoulder it. And I think that's why we're seeing a kind of a collective renegotiation of care responsibilities. So let me just give some very specific examples of why gross domestic product is very misleading in ways that are very much tied to the peculiar characteristics of the care economy. Think about this, when parents care for their own children instead of paying for care, that lowers gross domestic product. When mothers breastfeed instead of buying infant formula, that lowers gross domestic product. In the national income accounts, we see imputations of the value of owner-occupied housing that are very approximate, it's based on kind of rental value. Those were put in place because if they hadn't been put in place, an increase in home ownership would have reduced GDP because rent wouldn't be being paid. So, we couldn't let that happen. So those imputations were put into place very early in the national income accounts. But housework still is not, hasn't made it into the mainstream accounts. Also, to reiterate some points I made in my first lecture, family spending on children is labeled consumption. If you were raising other forms of living biological and social capital, your spending on feeding and caring for them and raising them to maturity would be considered investment, but not so for family spending on children. Public and private spending on health and education, how much is it? Well, we don't really, all we know is what the cost of the inputs is. We don't have any measure of the value of what is provided. No wonder healthcare looks expensive. All we're doing is we're valuing the inputs. We're not putting any value on the increased life expectancy or the increased health or improved mental health or improved, resistance to infection, et cetera, et cetera. It's basically a hidden output in both cases. So obviously, it's not going to yield, by definition, it's not yielding a quote unquote surplus, and that's really, I think, helps explain why economists have been rather relatively uninterested in thinking about it. So really important to drive home the point that the economy is just much, much bigger than the market. And we shouldn't think of the market as like the mother planet with their little satellites revolving around it that represent externalities or spillovers. We sort of need to reorient that picture and move away from conventional ways of defining income, wealth, and investment that are sending the wrong signals. We need to realize that the physical climate, like the physical climate, the social climate is vulnerable to disruption and dysfunction. And so we should be challenging conventional emphasis on GDP and treat it as only one of many different social indicators. Now, there are efforts underway, especially in the last 10 years, to develop satellite accounts to supplement market-centric measures. And I think these are important efforts that should be supported, even though they don't really, even though they're a bit insulting in their conveying the impression that they're somehow subsidiary or separate from, or just smaller than the market economy. They are at least putting a kind of quantitative measure on the value of unpaid work, and it may not be a very accurate measure, and it may leave out a lot of qualitative aspects. But let's not forget that unpaid work is currently being assigned a value in the national income accounts, and that value is zero, absolutely zero. So even a very approximate estimate of the value of unpaid work is, in my view, an improvement over the consistent tendency to ignore it. And satellite accounts are being developed not only for unpaid work, but also for natural capital, natural assets, ecological services. Satellite accounts are being developed for the healthcare sector and for the education sector. And I think what this means is that accounting itself is being revealed as a really important social scientific enterprise. It's not kind of the bookkeeping drudgery that we often thought of it as something, very theoretical, just nuts and bolts, double entry, are you using black ink or red ink to create accounts? Setting up accounts is really, it's the starting point of everything that we do when we model what's going on the micro or the macro level. And I think this is a theme that's going to be developed much more detail in later lectures with social accounting matrices, and thinking about how to move from social accounting matrices to kind of new forms of economics. I just want to call your attention to the really interesting empirical challenges of measuring those inputs correctly and trying to get a better grip on the value of the outputs. And there are a lot of really significant challenges to doing that just on a kind of descriptive conceptual level that I think that we need to focus on. And I'll talk about them in a little bit more detail in the discussion of time use survey data. But for now, I just want to take a pause. I'll throw out some exercises, discussion questions. I think, as before, it's probably best to start with questions or comments on what I've said so far. But here's some things to think about. The meaning of care varies from place to place. It's culturally inflected. The words themselves mean different things. Maybe it means something different to you than what it means to me, or how I've laid it out. I'd really like to hear more about that. It's also true that there is still a lot of variation and disagreement about how care work should be defined or how the care sector should be defined. Not everybody uses the same terms. Not everybody defines them the same way. It can be very confusing. I've tried to lay out my definitions I'm really interested in thinking about how we could move towards more consensus, because I think more agreement about these definitions is going to evolve over time, and it's gonna be really helpful. And then finally, the big puzzle that I don't really have an answer to, how are we going to go about remedying the underestimate of socially created value that's hard to privately appropriate? Is there some way to illustrate it more specifically? Is there some methodology that we could use? I'm not really satisfied with the existing alternatives. And so I'm really, really interested in some brainstorming about that. And with that, I'm going to be quiet and hope to hear what you have to say. And here we go. So a lot of what I'm going to cover in this presentation is a distillation of a report that I worked on for UN Women. I couldn't share it with you because it had initially, because it hadn't been officially released. But I literally it was literally just released last night, along with another paper by Jacques Charme on time use survey methodology. So I'm going to be working with a research assistant to get it posted to the Slack channel, and really looking forward to kind of trying to summarize it today. So I think really the best summary so far of kind of international comparisons of time use and also care jobs is this 2018 International Labor Office report. And it's just very comprehensive and very international in its focus. It's a very good reference. And it's also really influenced my thinking about a lot of these issues. So wanted to recommend it to you. I'm going to talk about 3 problems with existing time use surveys. First of all, really serious underestimation of the temporal constraints imposed by dependent care. And notice I used the word temporal constraints, not necessarily the amount of time devoted directly to dependent care, but the way in which it restricts options and possibilities for engaging in other activities outside the home, in particular paid employment. Secondly, maybe not so dramatic, but very aggravating, are inconsistencies in the measurement of direct care time across surveys, and kind of inconsistencies in survey design. And really, there just needs to be much more effort at international harmonization, and it needs to be a cost-effective harmonization. That is, we can't just be proposing bigger and more expensive time use surveys. We need to be thinking about ways of making them more feasible, and also really accommodating national differences and priorities. And we need to have a stronger voice at the table of discussion in national statistical offices and in the UN Statistics Division. So think about 3 conceptual issues. What do we mean by care? I mean, operationalizing it, not conceptualizing it, but talking about, like, what is it we're measuring? Secondly, what is an activity? What do we mean when we say that we're measuring activities? And then thirdly, why do differences between time diary and stylized activity list survey methods, why do these differences matter? And I'm going to argue that they matter because each of these approaches has its strengths, and neither of them in their pure form is really satisfactory. We need a little bit of a hybrid, in my opinion, moving forward. So I'm going to make a case for that. So here's the way I think about the 3 types of care. This came up a little bit in my first lecture, but I want to be explicit about it. 3 things: direct active care, sorry, waiting for a little noise in my environment to subside. These are unpaid services provided directly to dependents, face-to-face, first name basis, et cetera, conforming to the definition I gave earlier: feeding, bathing, dressing, reading aloud, driving to school, the doctor, et cetera. So that's direct active care. Direct supervisory care, being available to supervise dependents, sometimes called passive care, or in the Latin American surveys, estar en pendiente, and it often shows up, but it's not being it's really not being captured. If you think about it, the idea of a passive care activity is kind of a contradiction in terms of passive activity. Questions about passive care don't elicit very many responses. They're basically just not really working. Whereas this phrase, you know, to be dependent on or you know, to be on call, is really capturing very big responses. So the wording and the conceptualization. Here's the summary. Direct care is equal to direct active care plus direct supervisory care, but direct care is often combined with indirect care. That's the housework component. And supervisory care, this is really important, may also overlap with leisure. Okay, what is an activity? It sounds obvious, like you think you know what an activity is. But a lot of activities are conducted simultaneously or with such a rapid back and forth that they're virtually simultaneous. So some surveys distinguish between primary and secondary activities. But supervision is not really an activity, it's a responsibility. And that's why time-based, diary-based time use surveys underestimate it, because they cue people to report activities, and just being available is not, it's just literally not an activity. So I think this is sort of a crucial factor. So the two main methodologies, you may know this already, but some of you I know are not familiar with time use surveys. So here are the two main approaches. A diary-based survey allows respondents often to name the activities they perform, although sometimes they're just given a list they can choose from, but often they can actually just name them, usually over the preceding 24 hours. So it's a recall period where they're likely to actually accurately recall what they've been doing. Then their responses are coded into specific categories for tabulation. Most regions of the world, other than Latin America, rely on time diary-based surveys. At the other extreme are activity list-based surveys that are just asking respondents to remember how much time they devoted to specific activities, often during the preceding week, sometimes during the preceding work days, and then the preceding weekend, right? But it's kind of asking respondents themselves to kind of calculate an average amount of time. And most Latin American surveys are using the activity list approach. And I included an exercise at the end of this process that is gonna, you know, actually give you the practice filling out both forms, so that if you don't understand it right now, I think actually going through the process of the exercise could help you get it. So it's funny, I can't, my display is a little bit of this slide is a little hampered by the overlay of the Zoom thing, but it's basically the advantages and disadvantages of the two approaches. And most time use researchers really love the time diary approach, and they describe it as the kind of the gold standard, because it's shorter recall, more accuracy, there's less social desirability bias, because you're not asking people, you know, a loaded question about something that they think they should report doing. But because it's based on what you were doing, it really underestimates supervisory constraints. And activity lists have exactly the opposite strengths and weaknesses. Um, they explicitly ask people, or most of the Latin American surveys explicitly ask people, how much time did you spend supervising young children or supervising elderly, family members who were dependent upon you, who really needed you to be there, basically. And by doing that, by using that prompt, what they generate really high reports of supervisory time, which completely contradict the very low reports that you see in time diaries. And of course, you could argue that the people are exaggerating, or it's less accurate, or so forth and so on. And you would be justified in making that point, because the activity list surveys don't constrain reports to 24 hours. They ask people what time you spend in these activities, and you can report doing activities that add up to way, way more than the total hours in a week. So unfortunately, they're just not, the results from these surveys, and this is most Latin American surveys, are just not consistent with time diary-based surveys. And the biggest global problem with time use surveys is this inconsistency between the two surveys. And it's not going to be solved by just having people do time diaries. It's got to be solved by some hybrid, of, in my view, some kind of hybrid between the two. So if you look at the summaries, even in the ILO report, which is pretty careful about comparability, the amount of time reported as direct care in Latin America is just not comparable with most diary-based surveys, because they include these, simultaneous activities, people reporting time and activities that adds up to more hours in a day, much more explicit attention to supervisory care. And they also, and this is really important, they use a lower age category for children than affluent countries do. In countries like the US, we consider somebody under 18 a child. In a lot of developing countries, it's under 14 or under 12. So if, maybe you want 2 age categories or 3 age categories, but somehow you got to create more comparability on some level with the way you define children if you want to understand childcare. And even if you look at results across the Latin American surveys, they're a lot more comparable, but it's still really hard to compare. And I'm going to give you some examples comparing Mexico and Ecuador, because they ask about dependent care, but they define dependence differently. There are differences in the number and wording of care activities that are listed on the activity lists. And you could puzzle these problems out if you had access to the microdata and the metadata, the coding that is being used to generate the aggregate statistics. But often this is not available, so you can't really replicate the official tabulations, so you don't really know what assumptions are being made in the official tabulations. So it's really easy to get lost. So here are some examples, and I go into more detail in the UN Women report, and this is an evolving project, so these numbers may change. I just think it's interesting to kind of get into the weeds and look at 2 countries, Ecuador and Mexico, time use surveys, kind of not pretty much in the same time period. But the Ecuadorian survey only asked the question about time devoted to childcare to households with a member under age 12. The Mexican survey to those with a member under age 15. Well, that may not sound like a big difference, but in the Mexican definition is 25% larger than the Ecuadorian definition. So it's not surprising that you're going to get a different total for time devoted to childcare. The Mexican survey, but not the Ecuadorian survey, inquired of time devoted to direct care for adults 60 and older. It didn't specify whether they were ill or disabled, just whether they were 60 or older. That it's got to be, need more consistency there. Both surveys included care for non-dependent adults between the ages of 15 and 59. And it's small, but it's noticeable. Both surveys included, so, 2% for women and men, 6% in Mexico, but 0% in Ecuador. So what is care for non-dependent adults? Well, it's mostly housework. It's that indirect care, and including it as care, it's just really hard to net it out. So we should be thinking about it. Sorry, was there a question? Did I hear someone? Are you with me? Say you're with me.
We are.
Oh, great.
Yeah.
Thank you. It's just, I feel like I'm in a different universe, which I kind of am. Okay. Supervisory care. Both the Ecuadorian survey and the Mexican survey included measures of supervisory care. Estar en pendiente de. But the official tabulations of the Ecuadorian survey omitted these, while the Mexican survey tabulations did not. Ooh! Quantitative significance of supervisory care is huge. Time devoted to that represented the largest component of all direct care hours, 63% for Mexican women, 58% for Mexican men, 50% for Ecuadorian women, 42% for Ecuadorian men. So we're not talking about little numbers here. And we don't really know why differences in average supervisory care of children, they're actually greater than differences in average direct active care time. This could be the result of differences in survey administration or enumerator training. We don't really know. That's why I think we need more harmonization and calibration on the kind of regional and not just on the international, but also on the the regional level. And wow, I tried to do a lot of detective work, puzzling things out. So in both countries, both the average and the median hours reported was actually below the total number of hours in a week, including sleep. So there was all this simultaneity, but there was also clearly some underreporting in these activity list surveys. And I think it's interesting and telling that women were much more likely than men to report activities summing to more than 168 hours. Why is that? Because they were multitasking more. And in particular, they were combining supervisory care with leisure activities and unpaid housework to a greater extent than men. So, I don't know. I don't want to get too lost in the details here, but there's just only so much you can do to try to puzzle out the limitations of the methodological differences. One thing I was worried about was that both surveys, and this is a really good feature of both surveys, that collected data from all household members 12 years and up. I think that's great because you can look at like the total amount of care that the household provided, not just one individual in the household. But one might worry that a lot of household members might have been reported that they were supervising children at the same time. And really, however important supervision is, you don't really need more than one adult to do it at a time. I mean, that's why it's such a constraint on women. So it could be that total supervisory time was overstated as a result of that. So I went through the process of restricting all of the samples to households with only one child under the age of 5 and kind of deriving a benchmark for the total amount of supervisory time required, kind of lower bound estimate. And it doesn't appear to be overestimated. That is, the total household supervisory care provided is kind of less than what you think of as the benchmark. What I mean for a benchmark is kind of the legal norm that you can't leave a child under the age of 5 alone, or you shouldn't be leaving them alone unless there's another adult or older child around to look at them. And I think that gives us a kind of fulcrum, a kind of standard by which to ask, well, how much time, how much of the supervisory time is being reported compared to how much we think is probably just kind of a legal and cultural requirement for the attention to children under the age of 5. So okay, this slide is just summarizing kind of what I've already said. I think the activity list surveys are capturing something really important that the time diary surveys are missing. This responsibility that's not really an activity. But the disadvantages are that you're not constraining the results to a 24-hour day. And that's why I think there needs to be a lot more kind of methodological research. How important are these methodological issues? The ideal way to figure that out would be to administer different surveys to comparable groups of people and see what the results are, how sensitive they are to survey wording, et cetera, et cetera. And there's been some work on this in Mexico, but I think we need more work of this type. And here's again is where qualitative research could be quite useful. So just an example of the nitty-gritty issues of relying on time use data. And so I hope this was a good use of your time.